Okay, so when we're looking at the various products that are available for treatment of Alzheimer's disease, you can see the products listed here and their general indications through the FDA. So our antibodies for amyloid beta are aducanumab and lecanemab. These are indicated for mild cognitive impairment, so they shouldn't be used in moderate to severe disease. If you remember, that is 17 or less on the MMSE is moderate to severe. Donepezil, also referred to as Aricept or Adlarity, is approved for both mild to moderate and moderate to severe Alzheimer's dementia. Whereas galantamine or Razidine is just mild to moderate, and rivastigmine or Axalon has both indications for the oral. Package labeling for the patch only indicates for the mild to moderate. I won't get that tricky from like a specific perspective for test taking, but that is something to note. We have our NMDA receptor antagonist, which is memantine. There's one product here, but they are both products, the combination and the singular formulation, are approved for moderate to severe. So that is a difference there. Mild to moderate, it does not have that approval associated with it. So we have our acetylcholinesterase inhibitors, NMDA receptor antagonist, and our amyloid beta antibodies. So how these work, the amyloid beta antibodies work to reduce the effects of the beta amyloid changes over time in the brain and can be considered potentially a disease-modifying treatment. However, again, they're not really incorporated in the guidelines yet, so we don't know the full space with which it's going to encompass, and there's some risks associated with it that we'll talk about. So when we think about acetylcholine and its association with Alzheimer's disease, there is essentially a reduction in the production, utilization, availability of acetylcholine. So acetylcholinesterase inhibitors, so if we see esterase, that's usually an enzyme that breaks things down. We inhibit that enzyme, so that will increase the availability of acetylcholine. Our NMDA agent, so Namenda, actually works to block and modulate the activation of our NMDA receptors. So these guys. And NMDA receptors help modulate the activity of glutamate. And glutamate is an excitatory neurotransmitter. So with sustained activation of NMDA receptors, we can see toxicity. So there's really a balance when it comes to neuronal activity and receptor activation. Excess activation can actually kind of burn out the cells a little bit and cause cell death. So we can either modulate our NMDA receptors or increase the availability of acetylcholine. And of course, we have our antibodies as well that can help to reduce that production of the beta amyloids. So the first agent I want to go over more specifically is donepezil or Aricept or Adlarity. This is indicated for mild to severe Alzheimer's disease, and this is typically taken at bedtime. Food is not super important here. There are some that are a little bit different there. But we have some different formulations. So we have our standard oral, which is 5 or 10. We have the high dose, the 23 milligram tablet, which should not be crushed or chewed. But we do have an ODT, or an orally disintegrating tablet, which should be placed on the tongue and then taken with water. There's a patch that's an every 7-day patch. So it gets rotated every 7 days, which is pretty nice and can bypass some of the gastrointestinal effects. And when we're thinking about dose adjustment, we want someone typically to be on the low dose for around a month before adjusting up, just to make sure that tolerability is appropriate. This is a CYP3A4 major substrate, so is implicated in some drug interactions with that cytochrome P450 enzyme. Rivastigmine comes in an oral or a patch formulation. You don't have to worry too much about this conversion. It's just more for your information. This is a daily patch, however. So we have the oral formulation and the daily patch. Oral formulation should be taken with food. So something to be noted on. There's a fairly wide variety of spaces that the transdermal patch can be placed, and the recommendation is to try to avoid reapplying in the same space for 14 days. This, again, should be adjusted around every month. You can do it a little bit sooner, but my general recommendation is once a month to increase the dose if they tolerate it well. If someone does not take their medication for 3 or more days, then we have to actually dose it back up. Okay, so that is something to take into consideration. There is some effects with individuals who are nicotine users. Clinically speaking, we would really just dose adjust if there's a lack of response, but we don't do a lot of stuff preemptively with that. Whoops. Galantamine is for mild to moderate and should also be taken with food, just like rivastigmine. There's an oral solution available, which needs to be mixed and diluted prior to administration. Similarly, we have that monthly titration and retitration if 3 or more days are missed of the medication. There are some dose adjustments for low creatinine clearance. So really anything less than 60 is the cutoff to keep in mind. It is a substrate for 2D6 and 3A4. So we do take into consideration potential for changes in response and tolerability. If someone, let me move my mic. Whoops. So you can see the full slides. That's the only hard part about this. Oh God, there we go. Nope, wrong one. There you go. Just making sure you can see the whole slide. All right. So monitoring for that toxicity. Let me fix my thing. Oh my God. We're just going to start getting like more and more chaotic as I make more and more videos in this series. All right. When we're thinking about the utilization of acetylcholinesterase inhibitors, tolerability is certainly a concern. I got a little like stomach hanging out over here that you can't see because I don't actually know how like green screens work. There we go. So when we're looking at acetylcholinesterase inhibitors, think about anticholinergic, but the opposite, right? So anticholinergic effects are very drying, right? Decreases salivation, decreases tear production, decreases ability to urinate and defecate. This is the opposite, right? So people get kind of goopy. They can experience a lot of nausea, vomiting, diarrhea. They can experience weight loss and loss of appetite. Now, the GI effects are reduced a little bit if someone's taking the transdermal formulations, we believe. So we're going to just monitor for weight loss, monitor for significant GI complaints. I've had patients that have really struggled because of the diarrhea associated with it, especially if there's limitations in mobility or access to bathrooms very easily. We can give it some time. The body can adjust to it over time, but we do want to think about that quality of life because at the end of the day, that's what we're focused on. There is an increased risk of peptic ulcer disease or GI bleed, so educating your patients on signs and symptoms and increasing that monitoring if someone is on another agent or intervention that can increase risk of GI bleed. So, of course, we would treat it if they develop a GI bleed associated with use of an acetylcholinesterase inhibitor. We wouldn't use it anymore. The central nervous system and cardiovascular effects. So when we utilize acetylcholinesterase inhibitors and increase acetylcholine availability, that can result in some sedation, dizziness, but we can also see the heart rate drop. So we do monitor for heart rate. We screen for any symptoms of dizziness, increase in rates of falls. There are some risks for things like angina and myocardial infarction and blocking of some of the electrophysiology of the heart. So we do monitor for signs and symptoms and changes in heart rate. Usually the dizziness is transient, but we do want to make sure because some of our population might be on a number of different medications that can also affect heart rate or cardiac conduction. We want to make sure that we're keeping those things in mind as well. One other thing that is notable is the risk of experiencing some strange sleep disturbances, particularly changes in dreams. So we do see that with things like nicotinic activation, acetylcholine activation, a lot of mental health medications, people will have changes in their dreams. So really screening to see if that is concerning for the patient. If it is, we can move the medication to earlier in the day, and that sometimes can relieve some of those symptoms. All right, so moving into memantine, again, it's moderate to severe, so it's not typically utilized for mild Alzheimer's disease. This is an NMDA receptor antagonist, so it's working on that glutamate system and does not have to be taken with regard to food. When we're looking at the oral solution, this is not something that's mixed, unlike the previous medication that we had spoken about, the galantamine. And you can also sprinkle the ER capsule contents into applesauce. I talk about the liquids and utilization outside of our standard oral medication use because we do have some increased prevalence of things like dysphagia and difficulty consuming food by mouth that just is more common in this type of population. This can be titrated a little bit quicker than the month that we tend to recommend for our acetylcholinesterase inhibitors. So we can increase at weekly intervals. There is dose adjustment with a creatinine clearance of less than 30. If someone is taking a medication that is a urine alkalinizer, it can decrease the clearance of memantine. So we may just need to watch for tolerability concerns in those instances. Biggest adverse effects does tend to be a bit better tolerated than our acetylcholinesterase inhibitors. Usually things like dizziness, headache, some mental status changes. We do sometimes see worsening or presence of hallucinations as a result of that. I had a gentleman one time that started on donepezil for his dementia and couldn't tolerate it due to the diarrhea. He was still in like the mild to moderate phase, but we didn't have a lot of options. We switched over to memantine, did okay overall, but had this prevalence of hallucinations that fortunately were not disturbing to the patient, but still can be pretty problematic. So certainly something that we do see. A lot of the dizziness, headache can be pretty time limited, but certainly screening for hallucinations is important. This can kind of be mixed when it comes to gastrointestinal effects. However, if someone experiences constipation with memantine, which can absolutely happen, combining with acetylcholinesterase inhibitor can kind of have almost a positive pharmacodynamic interaction. Our combination product that I had mentioned before, the Nimzeric or memantine donepezil, is the two things together, right? So our Aricept plus memantine. Again, this is not for mild. Oh God, I can't even get out of the way for this one. Not mild. You can see the slides posted, so you're good. Not for mild. Should typically be taken at bedtime. Does have the ability to sprinkle over applesauce and that dose adjustment for creatinine clearance less than 30.